And thank you for joining us today. My name is Fiona Evans. I am the Director of Patient Advocacy here at Massive Bio. I am joined today with Dr. Jose Sandoval Seuss, who is going to be discussing mantle cell lymphoma with us. I'll let you introduce yourself, Dr. Sandoval.
Hi, good evening, everybody. Late afternoon, early evening. My name is Jose Sandoval. I'm very pleased to be here. I am right now an associate member the Department of Malignant Hematology and Cellular Therapy at Moffitt Cancer Center. I have been here for almost 6 years now. My main role is seeing patients with lymphomas, both patients that are just starting treatment or just diagnosed. Some of them are not on treatment, and some of them, the disease have come back one or several times, and they have been going through a lot of different treatments, including transplant, CAR T cell therapies, and so forth. That they're some of the things that we're going to talk today about. Thank you, Massive Bio, for the invitation, and very glad to be here.
Thank you so much. We're so happy to have you. I know we've talked before in the past, so welcome back. So, can you tell us, what is mantle cell lymphoma, and how does that differ from other types of lymphoma?
Absolutely, Fiona. So, mantle cell lymphoma, it is a type of B cell non-Hodgkin lymphoma. Those non-Hodgkin lymphomas that we have discussed here before, they are cancers from a special type of blood cell that are called lymphocytes, right? These lymphocytes, they are born in the bone marrow, but they all go all through our body through different sort of quote unquote channels, right? One of them is the bloodstream, and the other one is the lymphatic system. And they are sort of like interconnected with these training stations, if you will, that we call them lymph nodes. And we have more than 200 lymph nodes all around the body, and that's where these lymphocytes they develop, they grow, they learn to fight for us, right? They're the immune system, so they're our own personal army. And there's a lot of these lymphocytes. Some of them we call T cells or T lymphocytes, or some of them are called B cells or B lymphocytes. We all have these cells, and we need them to be alive to survive. But sometimes these cells they just keep dividing, and they gain certain type of mutations that encourage them to divide, right? And without control from the body, because they sort of like overrun those natural controls, and then they create these malignant cancers from these lymphocyte cells that we call lymphomas. So usually, for the most part, are located on the lymph nodes, but they can be in many other parts. They can be on the bone marrow, on the original factory of blood. They can be on the gastrointestinal tract. They can be on the central nervous system, in the skin, you name it, everywhere. They're probably the only place that we don't have potential areas for lymphoma involvement will be the cornea. Interesting enough, because there's
Sure.
no vascular tissue, there's no vessels there. Anyhow, so mantle cell lymphoma is a very weird, if you may, type of non B cell from B lymphocytes, B cell non Hodgkin lymphoma. It accounts more or less for 6%
So
of
rare.
all non-Hodgkin lymphomas, and this it differs from other lymphomas. One that is weird is not among all the non-Hodgkin lymphomas that are already not very common diseases. This one is quite it's quite strange. It's not very common, and it comes from some specific type of B lymphocytes from the lymph nodes. One area specifically on the lymph node that is it's called the mantle cell area. So that's why we give the name of that. So, and it also it's a quite curious and interesting lymphoma in a way, because it sort of like has characteristics of both worlds, if you may. Because when you talk to a patient, and that's the way that I explain to my patients to see non-Hodgkin lymphomas, is that non-Hodgkin lymphomas, specifically B cell non-Hodgkin lymphoma, we can see them in two different ways. One of them, they are quite aggressive lymphomas that they come very fast, they grow very fast, and they will manifest with symptoms very fast. And those lymphomas, they're sort of like the poster boy in a way for that type of lymphoma, and is the most common one actually, is called diffuse large B cell lymphoma. And we need to treat that lymphoma almost immediately with immunotherapy and chemotherapy to try to cure it. And we have a good chance to cure it. All right. Now, in the
Right.
other spectrum, we have these indolent, quote unquote, slow growing B cell non Hodgkin lymphomas that, they grow very slowly in time. And sometimes we don't even have to treat them. The perfect example is one that is called follicular lymphoma and another one that is called a small lymphocytic lymphoma. That sometimes patients present with lymph nodes and they have them for years and years and years, and we don't have to do anything about it. However, when people need treatment, when patients need treatment for these lymphomas, we can control it very well. We can place them under remission or under control for many, many, many years. But unfortunately, we cannot cure these diseases. Now, mantle cell lymphoma stands in the middle because it is a
Okay.
disease that can present sometimes in a very indolent or sort of like slow growing pattern. And we don't have to treat the patients at the very beginning. We just have to follow them very, very, very closely. But at the same time, sometimes they can present in a very aggressive way, and
Mm.
we have to treat them as soon as possible. Or if not, it carries a lot of morbidity and mortality if we don't do anything for the patient. So it stands in the middle of both worlds, if you may.
Got it. Okay. So, with this, with mantle cell lymphoma, what is the most common treatment for it, and how effective is it?
Excellent question. So nowadays, mantle cell lymphoma, let's say 10 years ago, 15 years ago, mantle cell lymphoma was seen everything with the same, under the same sort of like spectrum. It was
Mhm.
seen as a very aggressive disease that we need very aggressive treatment right away, or if not, the patient is going to be in trouble. Nowadays, we know that we have sort of like two types of mantle cell lymphoma presentation. One of them that is the classical mantle cell lymphoma that presents with big lymph nodes, multiple areas of the body, and the patients present what we call constitutional symptoms or B symptoms in a small proportion of patients, usually less than 30%. That is, weight loss, fever, unexplained fevers, and severe sweating, especially at night. Or you can also have involvement of other organs, like the gastrointestinal tract is quite common, or the skin. Uh, Really not very common at the beginning, the bones and the central nervous system. But suffice to say, that is the classical mantle cell lymphoma that we know of, that
Mhm.
patients usually need treatment right away. And I'm going to talk about what type of treatments in a minute. Now, the other spectrum is something that we call uh, leukemic non-nodal mantle cell lymphoma. Interesting enough, it presents with a lot of white blood cells, sometimes in the bloodstream, all right, and with a big spleen, all right. And sometimes we know now that that is about 15, it's usually less than 30% of patients, anywhere between 15 to 25% of patients, that
Mhm.
we can watch these patients very closely, even up to 2, 3, 4 years, and sometimes they don't need any type of intervention. All right. So I just want one of the messages nowadays that things have totally changed in the past 10 years or so is that not everybody needs treatment right away. There's a portion of patients, I would say a little bit less than a third of patients, again, less than 30% of patients, that we can closely watch in active surveillance without any interventions as soon as we diagnose the patient right away. Now, when the patient needs treatment, all right, we usually see the patients in two different big ways, right? So I'm going to talk about frontline therapy. Yeah, when the patient presents, initially is diagnosed with mantle cell lymphoma and needs treatment for the first time, all right?
Mhm.
So we divide that in patients that are fit, they are healthy, and they're usually less than 65 years, like 65 years or less, all right? But
Okay.
it's more than the age per se. Is more, it's also the fitness of the patient, right? In terms of like how strong the patient is in their daily activities of daily living. uh,
Mhm.
if the patient has other diseases, comorbidities, right? How the heart
Right.
is doing, the kidneys, the liver, etc. Now,
Mhm.
if a patient is fit, has a low comorbidity index, or not a lot of other diseases that are, putting in trouble his health, and is usually 65 years or less, we usually, it's not a standard of care, but what people usually do for the most part is a chemotherapy combination with immunotherapy. The immunotherapy is something that we have been using for many, many years, that is called rituximab, all right? And
Mhm.
then we combine it with chemotherapy. There's a lot of types of different chemotherapies. The one that is more commonly used here in the United States, it's called bendamustine. But I'm gonna put that aside for a minute. But usually in these fit young patients, usually for the most part, I'm gonna tell you until last year in general, what we do is that we give a couple of cycles of this chemotherapy with immunotherapy. Can be other chemotherapies. Usually we want something that contains a chemotherapy that is named cytarabine on it.
Mhm.
Okay, and there's a lot of cocktails or combinations for that. We give
Right.
a couple of doses, a couple of cycles. We call induction. We is usually, for the most part, very effective, right? Very effective in the range of putting the patients in complete remission up to above 70, 80% or so. And if the patient does well, tolerates treatment well, goes to a complete remission, then usually what we do is that we take the patient for a procedure that is called an autologous stem cell transplantation from peripheral blood, meaning that stem cells that they come from
Mhm.
the bone marrow, but they're swimming around the blood
Right.
from the same patient. All right. And after that, and this is one of the most important interventions for patients, either if they go to transplant or not, that is, we give maintenance rituximab, meaning a dose of rituximab every 2 months for two
Mhm.
to 3 years. Usually, we do it for 3 years in this disease, according to the studies right now. Okay.
Okay.
Now, for folks who are 60 above 65 or a little bit more infirm, that we don't think that they're gonna do well with very aggressive chemotherapy and procedures like a autologous stem cell transplantation, we usually do a chemotherapy regimen, and that's where the other chemotherapy that I was telling you about that is called bendamustine. We
Mhm.
usually do that with a monoclonal antibody, this immunotherapy called rituximab, and then we do rituximab maintenance, okay?
Mhm.
And
Got
usually
it.
for 2 or 3 years. And that's usually what we have been doing in general, right? For this
Mhm.
treatment. However, there are other, and they are quite effective. Okay,
Okay.
usually for the most part, I would say for more than 85% of folks with mantle cell lymphoma, treatment actually the disease responds really well to treatment. All right, they got a lot of them in a very high proportion, they go into remission. The problem is to maintain that remission. All right, and
Right.
what has improved our capacity to maintain the remission is the autologous stem cell transplant one, but especially giving that rituximab maintenance afterwards. Okay,
Mhm.
so that's why again the importance is try to maintain treatment. However, just and then just to finish up this part, there's other alternatives for patients who really are not interested in chemotherapy, or especially for patients who have very high risk features on their disease. What are the high risk features on the disease? Just to make a parenthesis of that, there are certain markers that your doctor will tell you about, and they will make sure that they get on the biopsy or in the blood when
Mhm.
they initially diagnose the patient. One of them is something that we get on the biopsy that is done by the pathologists, that are the folks under the microscope, right? That is
Mhm.
called, it's a marker that is called Ki67, that it's sort of like tell us how fast those cells are dividing. And if the
Okay.
marker is above 30%, it's usually more of a more aggressive player there in that mantle cell lymphoma. If the lymphoma has mutations on a special gene that is called TP53, that is the
Mhm.
gene that is in charge of DNA repair and so forth. If there's some mutation on that gene, or is a deletion of that gene doesn't exist on the cells, that is also a harbinger for a more aggressive disease. And if the pathologist also sees under the microscope, sees that the mantle cell lymphoma has a certain morphology or certain features that are called pleomorphic or blastoid morphology, or those are technical names. That means that there's a lot of cells that are dividing very fast and they're very immature. That is
Yeah.
also sort of like a marker of that mantle cell lymphoma is going to be a little bit more trouble. For those patients, there's a lot of studies, especially in Europe, that they have demonstrated that being aggressive with a lot of chemotherapy is usually not very effective. And there's other, and this is not okay. This is not like sort of like a standard of care for a lot of people. The best way to be honest with you, in that setting, will be a clinical trial, and we're going to talk about it. All right.
Yep.
There's all, some aside from chemotherapy, there's other combinations. For example, there's a combination with rituximab and a medication that is called lenalidomide. That we have quite a bit of experience here in Muffin and other centers with that. So there's a lot of options that they're quite effective, at least at the beginning, and sometimes for a long time. But it's still the sort of like the challenge is to keep the disease under remission, under control for many years, so that patients can live their normal life for many years.
Yeah. Yep.
Mhm.
Absolutely. So I know you mentioned it just briefly. So how do clinical trials work? And how important, I know how important they are overall, but how important are they for mantle cell lymphoma patients?
Well, they're that's an excellent question. They're incredibly important, right?
Hmm.
So again, how do they work? I mean, the clinical trials, there are a lot of different types of clinical trials, right?
Yep.
We're going to start, of course, talking about human clinical trials, right? So there are multiple phases, and that's a conversation for a whole other hour. But there are
Right.
multiple phases of clinical trials. Usually we start with when there's a new molecule, a new medication, new intervention for patients. We start early on to prove that it's safe, okay? And obviously, we want to see that it has some type of effectiveness on the disease. But above all, and we need to be very honest with patients about this, when we do a phase one clinical trial, right, we're trying to prove that is actually the medication is safe, above all, okay, that the medication, the intervention is safe. And of course, we want to see that it has some activity, but it's safety above all.
Right.
Now, after we're proving that it's safe, and sometimes nowadays we bundle these two type of phases of trials. Then we go to what we call a phase two trial. That is when we are trying to prove effectiveness, that the medication or the intervention works for a certain disease, and in this case, this type of lymphomas. Those trials, they can be single arm, meaning that everybody will get the treatment or the intervention that we're trying to prove that works for patients. Of course, that is safe, but that works now. That we're trying now to
Right.
prove that it works. It can be single arm, meaning that everybody gets the medication, all right? Or it can be randomized. And usually in cancer medicine nowadays, clinical trials usually don't, for the most part, for the great most part, they don't randomize people, meaning they don't put in a group where they're going to take what we call placebo, right?
Placebo.
The
Right.
intervention that is not doesn't have the active component or anything like that. Nowadays, what they do when there is randomization, all right, way that you're in one group you're going to be with the active therapy plus a standard of care, and in the other group you'll be with a standard of care control arm. So that can be
Right.
also in a phase two trial, all right? Now, then we go to the phase three trial. That is the trial where we go for the approval, trying to get an approval of a new agent or a new combination of agents by the here in the United States, by the FDA,
Okay.
that has shown to be very promising in early phase clinical trials, promising, that is very active and safe for
Hmm.
patients. And here, usually those are very big trials by hundreds and hundreds of patients, right? That usually they should be randomized, right, to prove that it's better than the other one, and that I say, and is as safe or safer than the other one, right?
Right.
So those are usually the big type of trials in oncology and in other areas of medicine. But in oncology, we're very big on doing these trials, of course, to help patients. Why? How are they important in mantle cell lymphoma? I can tell you one story, a little bit of mantle cell lymphoma. Is that it's not that old. Actually, it has my age. Because actually it was originally described in 1982. That's the first time that they diagnosed, identify mantle cell lymphoma as a different entity. All right,
Yeah.
and initially it was a very terrible disease, right? Because they didn't know what we're
Right.
dealing with, how to know how to do it, and so forth. And it went from patients only being alive and well for for usually less than 3 4 years, and nowadays usually in the last numbers that we have seen, patients are alive and living well after 8 10 years or so, right? With all the things that are going. I'm talking in general, right? I mean,
Hmm.
there are some mantle cell lymphoma patients that are have a disease that is more slow growing, and there's some other ones that have a way more aggressive disease. that it might act different. So how do we do this? How do we do this? Through research, through clinical trials, right?
Right.
And there could be other clinical trials actually that they're not intervention clinical trials, right? The patients come to the clinic and they say, ma'am or madam or sir, uh, is it okay to participate in this clinical trial? What does it entail? It's a blood sample, and for you to give us permission of doing some tests on your biopsies, right? Even with that, the field has advanced, and it's through clinical trials that we have all these. We're going to talk a little bit later about it. That we have all these amazing therapies that are way more effective than before, and the uh, survival of our patients with mantle cell lymphoma and their quality of life have improved dramatically. And I can give you
That's
some
great.
examples of that later on. But that's how important they are in mantle cell lymphoma clinical trials.
That's great to hear. I'm so happy to hear that. Um, so how do I know you touched on it, but how do clinical trials help advance our understanding of mantle cell lymphoma and also improve, treatment options that are out there? It sounds like that has already happened greatly in the last 40 years, but I'm sure there's more to do, more work to do.
40 years. Oh, well. Yeah,
Yeah.
no, you're right. So, and that's a very good question. It's sort of like, sort of piggybacking, sort of like the other thing that we were talking about before, because, and I'm going to tell you about something. For example, through research, all right, through preclinical research, we identified what are the most aggressive mantle cell lymphomas, and then we took that to the clinic through other clinical trials. And then, for example, we identified what works for patients, what definitely doesn't work with patients. Not everybody needs aggressiveness and the side
Right.
effects of chemotherapy and things like that, because we know that it's not going to work very well, or simply because not everybody needs to get treatment right away. That was for clinical trials and research. That's one.
Yeah.
Now, something that has been incredibly impactful is the treatments that have been developed, all of them, through fast stream clinical trials here in the US and other places around the world. Especially Europe, they have a very, very strong mantle cell group, okay, of the treatments that have been implemented as a standard of care at the time when mantle cell lymphoma relapses. Okay, when we call relapse or refractory mantle cell lymphoma. The prognosis of our patients with mantle cell lymphoma, that when the disease came back at time of relapse, used to be
Mhm.
quite poor. Unfortunately, like sometimes they remain with us only for less than a year or so.
Yeah.
And the initial, and there were no before 2000s, there were no really like approved medications at the time of relapse mantle cell lymphoma. Then some of the medications were slowly getting approval. Some of them are now a little bit older. One of them is called, we already talked about it, called rituximab and lenalidomide. That was proven in another type of disease called multiple myeloma before, and then through research for clinical trials, we know that is very active in mantle cell. Then another medication that is called bortezomib, also that it was active in mantle cell, in multiple myeloma, and then through clinical trials, we know that it's active in mantle cell lymphoma. Another medication called temsirolimus, et cetera, et cetera, et cetera. But if you see how active were those medications, the response of our patients, meaning how they shrink the disease by half or more, were in the order of 30% or less, which is quite disappointing, right? Now, coming a little like in the last 10 years or so, a little bit more than 10 years, there's through clinical research, through phase 1 and phase 2 trials, came medications like that are called, and this actually revolutionized the treatment of these patients through clinical trials, that are called BTK inhibitors. That
Yeah.
they're active against a lot of malignant hematological cases, including CLL and so forth,
Mhm.
but they're quite very, very active against mantle cell lymphoma. The Harbinger, that one, the first one was called ibrutinib, that is very, very famous.
Yeah.
And then they came very effective, but we needed a little bit more. So they created through clinical trials. They came along uh, the second generation BTK inhibitors, that both of them are approved for mantle cell lymphoma. And you see that the change was, we went from giving high doses of chemotherapy at second or third line to taking oral medications that are much more active and much better tolerable.
That's
Uh,
great.
so it's the best combo of all, right? I mean, that's the best doublet, being active and being safe. And now we have second generation BTK inhibitors. One of them is called acalabrutinib that is approved in mantle cell lymphoma. And there's another one that is called sanubrutinib that is approved for mantle cell lymphoma as well. Uh, and we didn't rest with that, and that's good, right? We kept advancing
Right.
through clinical trials. Everything through clinical trials got approved. Recently, only 3 months ago, 4 months now, more or less, give or take 3 or 4 months, there was a new one, a third generation type of BTK inhibitor that is called pirtobrutinib. And
Mhm.
that actually is very active when patients have progressed, or the disease has, not patients, but the disease, when the disease of the patients has progressed
Mhm.
after these second generation ones. This new pirtobrutinib BTK inhibitor actually is quite active to control their disease. So we're just making little steps towards a better control of the disease in the future. And there's a whole, and I'm just going to talk about one more agent, but these all have been through clinical trials. One of the landmark points in relapse and refractory mantle cell lymphoma came about 3 years ago or so, when there was an approval of a cellular therapy for mantle cell lymphoma that is called chimeric antigen receptor T cell therapy, or CAR T cell therapy.
Mhm.
And this is a very important thing. I'm just going to spend a couple of minutes on this, because this treatment that is on their own immune cells called T lymphocytes, or T cells from the patients, that are, through a process of bioengineering, they are sort of like empowered to directly recognize these mantle cell lymphoma cells and destroy them, right?
Mhm.
So it's sort of like a living drug, right? Because you give that to the patients back, and those cells grow exponentially, grow on their body. Is one of the most effective treatments ever seen for mantle cell lymphoma at the type of the relapse. And
Mhm.
they act both on patients who are very high risk, that they have all these high risk features on their mantle cell that we talked about, these mutations, and these really a very aggressive looking kind of cells growing. But
Mhm.
they're also very effective for the patients who have progressed, that not the patients, but that the disease has progressed
Right.
after they were taking these BTK inhibitors. Before the time of CAR T cells, the median time that the patients were alive after the disease came back, after taking ibrutinib or acalabrutinib or so forth, it was only around 8 to 9 months, and sometimes less. Now
Mhm.
with CAR T cells, some of those patients after treatment, they're alive and well and without disease after 1 year, 1 year and a half, and so forth. All of the patients on the clinical trial that was the one that used to get approval of that, all of those patients who had progressed after taking BTK inhibitors. So they were very high
Mhm.
risk patients. And the response rate, meaning how many patients decreased the disease by half or got rid of the disease, was 91. And
Mhm.
the complete remission, meaning how many patients did not have any evidence of disease, was 68% on these very high risk
Wow.
patients. So all of this was because of the help and the strength and our patients, right? Their family members and all the researchers, right, that have been doing this clinical trials through the clinical trials. It was all possible through clinical trials, because this is a very not common malignancy. It's incredible. It's a blessing for our patients, in the sense that a very strange type of lymphoma has gotten a lot of attention and a lot of development, which is I'm very grateful for that, but everything is based on clinical trials. That's how we advance the field, right?
Right, right. And you're so passionate about clinical trials. I love that. I love to hear it. And there's so many advances available. Like you said, it is just amazing. I love it. So thank you. So on to our next question here. You mentioned side effects. What are, some of the side effects related to mantle cell lymphoma treatments? And can they be managed? How can they be managed?
Yeah, that's a great question, and actually it depends on the treatment that we're giving, right? So
Yeah.
if you're using So we're using the classic chemo immunotherapy, right? That is sort of like I tell to my patient, it's just going to, if you go to a battle zone and you're begin with your bombers, right? I mean, you're sort of wiping out everything. You're wiping out bad guys and good guys, because that's,
Right.
well, like in war, you have collateral damage in that sense. So
Hmm.
at the beginning you're gonna have one of the most common side effects of all these treatments are decreased white blood cells, anemia or decreased red blood cells or anemia, and decreased platelets or the clutters, right? When there's decreased red blood cells, so you get a lot of anemia, patients can be very fatigued, they may require transfusions of red blood cells and so forth. When
Right.
the platelets are going down, if they're very low, patients might be at risk for bleeding, so they may require transfusion of platelets. Importantly, when the white blood cells go down, and unfortunately, this is something that is it's something that is very difficult to avoid because the mantle cell lymphoma itself is made of these white blood cells, right? So when they go down with our treatment, there's higher risk for infections, right?
Right.
So that's one of the most common side effects in this regard. In terms of the classical nausea and vomiting, we have gotten much better controlling that. So that's, yes, it's common, especially the nausea, but much better than before. Now, uh, immunotherapy rituximab usually is actually very well tolerated. Usually at the first time around, we need to tell patients that they can have it looks like an allergic reaction, if you may, like chills, sometimes fever, sometimes skin rashes, sometimes itchiness, and so forth. But it's usually we have a lot of experience with this type of immune therapies, these monoclonal antibodies, and we
Hmm.
have all the institutions that they give this immunotherapy that is standard of care. They have a special protocol to decrease those type of side effects and how to give them, especially the first time around. Now, that is usually very severe side effects at the very beginning. Not everybody is the same, right? Everybody's a little bit different, but they usually more at the very beginning and decreases the quality of life of patients at the very beginning. When it's
Hmm.
done, that is usually after 4 to 6 cycles, depending what they're getting, usually it gets better, right? Because it stops. Now, on the other hand, when we're using ongoing therapies, things like ibrutinib, acalabrutinib, sanobrutinib, that these are these BTK inhibitors, right? Or when we are using lenalidomide, that is another medication that is taken for a good while, either it's 1 year, 2 years, 3 years, ongoing, right? Usually they're much better tolerated than chemotherapy in that regard. In severe low blood counts, need for transfusions, or severe infections and so forth, peripheral neuropathy, the temporary damage to the nerve endings and so forth. But they have some other side effects that we need to take care of. For example, BTK inhibitors as a class, they have a couple of side effects. One of them is at the very beginning, they can have skin rashes, diarrhea, sometimes what we call arthralgias or joint aches and pains,
Hmm.
muscle aches and pains or myalgias. Sometimes we can patients for in general they complain of a lot of bruising because they alter a little bit the function of the platelets or the clutters,
Right.
and sometimes, and it has been actually, it has improved with the second generation BTK inhibitors. So if you compare ibrutinib to the second generation inhibitors like acalabrutinib or sanobrutinib, the side effects I'm going to tell you are a little bit better. All the ones that I told you, they're better, but the ones that are very important, for example, severe bleeding. What is severe bleeding? Bleeding from the gastrointestinal tract, bleeding inside your eyes, bleeding inside your brain, or alterations with the rhythm of your heart, we call arrhythmias, especially something that is called atrial fibrillation or other arrhythmias, other alteration in the rhythm of the heart, and things like high blood pressure. All of them are much less seen with these second generation BTK inhibitors. All right.
That's great.
However, remember something, right? What we need to be very proactive asking patients about side effects because it's a medication that is ongoing, right? So if you
Hmm.
have side effect that is ongoing, we need to make sure, and there's a lot of techniques, dose, holding the dose for a couple of days, decreasing the dose, giving some other medications for that, sometimes changing from one BTK inhibitor to another, etc. There's a lot of things that we can do to improve the tolerance and decrease the side effects of our patients, but we have to be very proactive and
Right.
encourage patients to tell us because it's an ongoing side effect that is potentially could deter the quality of life of patients. And then, we can talk about that all day, but CAR T cell therapies is one shot and that's it. But it does have a lot of other implications, very specific side effects of that particular treatment. All right. So it's
Right.
a long topic. Mhm.
Yeah. Yeah. Just as a side note there, when I talk to patients, I always tell them that if they enroll in a clinical trial, they get a little bit of extra TLC
Yes.
because they're monitored very closely,
Mhm.
to make sure that, they're not having those side effects, or if they are, their physicians are able to manage them. So,
Absolutely. Yeah.
very important to bring that up when, if and when you enroll into a trial.
Mhm.
So, next, what is personalized medication and how can it benefit mantle cell patients?
So personalized medicine in general, medication medicine is actually finding. I mean, there's a classic, definition that is finding the right medication for the right patient at the right time, at the right
Mhm.
dose, and to help that patient, right? I believe nowadays personalized medicine has been around for a while, but what we know because you need to find the patient. You see the patient and you see what is the best medication based on that disease. What is the best medication based on their other diseases, on their other medications that they're taking, and on their social situation, if they can come to the clinic and if they can afford it, so forth and so on, right?
Right.
Nowadays, personalized medicine is also driven a lot by genomics, right? About the markers of the tumor, right? About a lot of different tests that we do that, and there's a lot of different platforms out there, including Massive Bio and a lot of other things that actually can connect patients with particular clinical trials where they're looking for they're looking to use medications that target specific mutations, for those cancers, right? And nowadays, especially in research institutions or big cancer centers, a lot of the talking about mantle cell, a lot of mantle cells are being sequenced. What is that? That they're running molecular studies to
Hmm.
check out their DNA, their RNA, and so forth to come up with sort of like the genetic code of that particular tumor. And for one for prognostic purposes, mostly for research purposes, but prognostic purposes. But the other one, a lot of times to see if there is a clinical trial that is specifically trying to target specific mutations that specific mantle cell lymphoma on that specific patient has. That is usually the concept of personalized medicine, and is very important for mantle cell because a lot of these things like BTK inhibitors and there's another one that's called BCL2 inhibitors and so forth. There are based on a lot of these kind of concepts of certain changes that those cells have that they discover that in mantle cell lymphomas in general they have it. We are little in mantle cell lymphoma. We are a little bit behind on very personalized targeted medicines for certain different mutations. Like for example, if you compare to acute myeloid leukemia, all right, they're way more advanced in that part, but they're slowly getting there.
We're
So that.
getting there.
Mhm.
Right. Is sequencing ordered like as a standard in mantle cell lymphoma, or is that something that patients should be requesting from their doctor?
All right, so that's a very good question, and let me try to answer it in the best possible way because it's a little bit different. So in general, and we need to understand that more than 80% of patients with cancer in the United States are seen by my colleagues in the community, right?
Right.
People who see everything, right? In one day, they can be seeing colon cancer, glioblastoma, like brain cancers, and then they see a mantle cell lymphoma. That is not that common because it's a weird disease.
Right.
Now, so the thing nowadays, before we used to recommend to at least get sequencing of that mutation that I told you that is called TP53, because
Got it.
that mutation, I cannot stress enough, is very important for the prognosis of patients and in a personalized way to more or less try to choose the treatment for a patient in sort of, it's not straightforward, but more or less can give us a hint and try to look for a clinical trial for those patients because in those type of patients the best thing is a clinical trial. Now, Nowadays, with these new patterns, these new panels that we call next generation sequencing panels,
Hmm.
is much cheaper and convenient to do one that actually looks for a lot of different genes that in multiple different studies they have identified mantle cell lymphoma that could be important for the patient. A part of them TP53, TP53, but there's a
Hmm.
lot of one of them, so they get sequenced. However, I do think it's important to do it, and that will be my recommendation to do it.
Okay.
However, it is not a standard of care. If
Right.
you ask me, I would say that it's important to do it in every patient that will get treatment. All right.
Mhm.
But I can tell you that it's not a standard of care. All right. In
Okay.
general.
Yeah.
Mhm.
I know, at Massive Bio, we always recommend patients ask for that if it's something that, they haven't had done so far. But, I know some cancers, it is a standard test that's ordered. If you have lung cancer, this test is ordered. But for mantle cell, I don't think we're there yet. So
Mhm.
that's something that patients can keep in mind, that, they should be asking for that testing when they see their doctors.
I do believe I will recommend it, but at the time of treatment, but it's not, again, right now across the board, not a standard. Different from lung cancer,
Right,
different
right.
from acute myeloid leukemia. So it's
Mhm.
a couple of different things. Okay.
Yep, yep. All right. So, um,
But let me ask you a quick question. Then now that we're talking about personalized medicine, right, and the work that you guys do at Massive Bio. So in all of this, right, how does Massive Bio work with patients, their family members, and their healthcare providers to find the best option, to connect to the best option for clinical trials for patients with mantle cell lymphoma?
So, Massive Bio, I'll give you a little back history. Massive Bio was created by three people who were struggling when family members were diagnosed with cancer. They were struggling to find treatment options. And so they created Massive Bio to help patients, their caregivers, and healthcare providers to connect patients to clinical trials. So, Massive Bio offers a concierge service. We um, use our artificial intelligence based technology to sort through all available clinical trials to identify trials for patients that they are eligible for. And once our nurses do that, they provide a report to the patient's caregivers and also healthcare providers, sharing the list of clinical trials that are available for that patient based on their diagnosis, their medical and treatment history. Our tool sorts through all the trials, matching patients to over 100 data points. And we can also search based on geography. So, there are patients, as you said, that some of them are very well physically, they're doing great. Some are not doing so great. So, patients can come to us and say, hey, I'm looking for a trial. I can't really travel. Can you look for something close to home for me? So we do that. We can search, in your preferred area. Some people are able to travel or have families, in different states, and some in different countries even. So we can look for trials wherever the patient is able to travel. And then once they decide, either to go into a trial or wait a little bit, our nurses take care of them from that point on. They work with them to, for those patients that are kind of, we're watching, they don't need treatment right away. Our nurses are checking in with them every couple of months. When the patient has testing done, they're, looking at that and saying, let's look again. Maybe now is a good time for you to join a trial. If a patient needs a trial right away, we will do our search, and our nurses will help that patient get enrolled. If they say, yep, I want to, enroll into this trial, our nurses jump in and they'll schedule the first appointment at the trial site. We check insurance. Um, we take care of the medical records. We even, can take care of transport. So our nursing staff really goes above and beyond to get that patient from trial identification to enrollment.
And actually, that you talking about that, that is one of the challenges,
Yeah,
about finding clinical trials in mantle cell for patients. Remember, this is not a very common disease, and
right,
especially when our colleagues in the community. I mean, I live in an area where uh, really, I mean, it's not a really an in general an underserved area, but I think about our colleagues that work in the Midwest or in some areas of the South as well, all over the country, right? Where they're miles and miles away from big centers, right? That
right,
patients and their family members, they don't have the luxury, right, of just take the car and go and find a clinical trial. Even though if
right,
they look for it in trials, clinical trials or gov, oh, there's a trial here and there. It's very hard for them. There takes a lot of energy. Takes quite a bit of literacy as well to do that.
right.
And that is one of the challenges, to find good clinical trials for patients with mantle cell and some other diseases, but especially with these sort of like orphan diseases. Remember, we diagnose one case of mantle cell lymphoma for every 200,000 patients. So it's not a lot, So
Right.
so that's why in these cases, these services are not only you guys and other services are quite important to go beyond these sort of like challenges that we have for patients. And I firmly believe that that patients with mantle cell lymphoma, if we can find a clinical trial at any time of their disease journey, I think they will, at least talking about it, it will be on their favor. All right,
Yeah,
so that's one of the challenges, especially in rural areas, right?
right.
In underserved communities, minorities, and so forth. That they're all actually the ones that are very limited for these advantages of being in big centers and so forth. So these services actually acquire, but I believe they can be quite beneficial for them.
Yeah, absolutely. I agree 100%. And we do see a lot of patients, in those under um, served communities. They're seeing a physician in one physician office who doesn't have the resources to search through all of these clinical trials. So, we're able to jump in and say, doctor, here's a list for you. Look at it. Let us know what you think. If their doctor says, hey, this is a great trial for you, I recommend this, we'll work with them to get them into that trial. So we want to serve patients, their families, and healthcare providers, because we know how hard you guys work, how busy you are, and sometimes you just don't have, the resources available to search for through all of the trials.
Right.
So we're happy to do that.
Yeah, excellent. That's great.
Yeah.
Mhm.
So um, I think you may have touched on this, but can you share some of the challenges mantle cell lymphoma treatment presents to clinicians and the opportunities in developing new treatments?
Sure. I mean, we talked about that already in the sense that it's not a very common disease in general on the biggest spectrum of oncology, right?
Mm-hmm.
One of them. Some of those patients, it behaves in different types of ways. Some patients you don't need to treat them right away. Some patients present in a very aggressive way, and they will require treatment right away. And some of them they will respond well to the usual, treatments, which gladly is usually less than 15% of patients. So that those are all those challenges as well, especially the patients that remain on remission for less than 2 years, and the disease comes back in less than 2 years. They become a little bit of a challenge to me as well. So those things is quite challenging. There also a question about when should a physician order, an oncologist order certain markers. Do I have them available in my pathology department, right? Will they know how to interpret them, right? It depends on the institution where you are. So that could be another challenge as well. Uh, then access to clinical trials. Like we talk right now. It's quite a challenge, especially with the disease comes over and over and over again. Now, another thing that is a challenge is that we have developed very good treatments, especially cellular therapies, right? Even transplant at the very beginning, but especially these CAR T cell therapies and so forth. A big challenge of this, and I'm going to piggyback that with another thing. A big challenge of this is that they're only given in very specialized centers. One of them, they're very costly, they're very expensive, very
Hmm.
powerful, very effective, but they're very expensive, and they're only given in certain specialized centers, right? So there are several opportunities through clinical trials, and they're ongoing right now. They develop to create other alternatives that could be as good or almost as good as these treatments, and that can be probably given closer to home or by their practitioners. There's one through clinical trials. There's several clinical trials that are going on right now using certain modified antibodies that are called bispecific antibodies. So if you look at it, they actually, they grab one of the T cells that are like these CAR T cells, the T cells that are the vigilantes or the army, your own personal army of the immune system that they kill cancer cells, and they take the mantle cell lymphoma cells and the antibody, just put them together, like this, kind of like this e-harmony or online dating kind of thing.
Yeah.
They find the perfect match, right?
Right,
For
right.
one or the other, and then they kill the mantle cell lymphoma cells. But those
Yeah.
are antibodies that in the future potentially they can be given in the communities. How we do that? We're doing through, that's an opportunity. We're doing that through clinical trials. And there's a lot of other things that are coming along. And a lot of these new medications are being combined in clinical trials to think if a combination is better than single agent, and those are very not. We need to do very conscientious, very well done clinical trials, and they're ongoing, right? And there's some other new medications that are coming along the way that new targets. There's a target, for example, that is called ROR1. There's some other medications that are actually, they're called BTK degraders. They just sort of like degrade that protein called BTK and kill the cells very early on. But all of these are made through the clinical trial. So there's a lot of opportunities. But
Right.
at the same time, it's a challenge knowing the disease, how to treat this disease, because it's
Hmm.
very strange. It's not very common. What are the good markers? What are the appropriate markers that we need to order? What is the best treatment for patients, both at the beginning and at time of relapse? Okay.
Okay. Great. Great to know. Thank you. Um, so, how can patients and caregivers advocate for greater investment in mantle cell lymphoma research and access to clinical trials?
So first of all, we all have to be advocates of our patients, of course, but the
Right.
caregivers of the patients are the best that they can do that, right? So
Yep.
it's very important to go through. There's a lot of organizations that they have been advocating for patients and their families with multiple type of hematological cancers or blood-borne cancers in a way. A very big one is called. There's a lot of them, all right. I mean, I'm not endorsing anybody, but there's a lot of ones. One that is very famous that is called Leukemia Lymphoma Society.
Yep.
They have a lot of good information on their website for their patients and their family members. One, they also directly advocate, in government wise to improve the access to research and to clinical trials. They do actually, they sponsor clinical trials. They give grants for clinical trials, and they give a lot of help to the patients or the family members as well. A lot of small grants covering medication co-payments, covering transportation, so forth and so on. That's only one of multiple organizations. There's another different organization that I encourage patients to look for information there as well, that is called Lymphoma Research Foundation, and they're very very big in education for patients and family members, and they're extremely big on giving grants to young researchers, like early on researchers, to develop this type of innovative clinical trials that had advanced the field of mantle cell lymphoma. Those are all really good. So one of the most important thing for advocacy is getting informed, right?
Right.
Acquire knowledge, the
Hmm.
patients and their family members to being more of an advocate for that. And of course,
Right.
it's always important. We always trying to write to our local congressman, congresswoman to try to approve all those measurements to pass more money to the National Cancer Institute and so forth to do invest more on research, especially in these not common diseases, right? In these
Right.
diseases that are not common at all, right?
Yeah.
And
Absolutely.
also participating in forums like this. There's a lot of different societies. I can tell you one example. In Florida, we have the Florida Society of Clinical Oncology, where we do these programs that are small town halls for different type of diseases. One of them is
Right.
lymphoma, that is, direct interaction with people like me that we do this for a living, treating lymphomas, treating patients with lymphoma, okay,
Right.
and answer direct one-to-one questions about everything that we have been talking like that. That's also empowerment. That's also advocacy and so forth. So, and there's a lot of different, services like Massive Bio can also help to empower and advocate patients. Helping them finding the appropriate clinical trials and so forth and so on.
Absolutely. And we're happy to help any patient that comes to us, locate and enroll into a clinical trial. So we are actually now going to watch we're going to show a documentary summarizing the discovery of lymphoma and treatments available today, and also how Massive Bio can support patients with lymphoma. So that'll be showing in a few seconds. You can submit your questions in the comments and we'll answer them right after this video. It's going to be about 5 minutes long. Thank you.
Blood cells called lymphocytes can undergo changes that make them grow out of control and cause a form of cancer known as lymphoma. Lymphoma is really two different cancers, called Hodgkin lymphoma and non-Hodgkin lymphoma. These diseases share some similarities, but they're also different in important ways. Both types of lymphoma begin in the lymph nodes, which are bean-shaped structures that make and store lymphocytes. Lymphocytes travel throughout the body in a network of tube-like vessels to fight infection. Both Hodgkin lymphoma and non-Hodgkin lymphoma begin when a malignant tumor forms in a lymph node. That cancer can spread to other lymph nodes or organs. In Hodgkin lymphoma, cancer tends to spread to nearby lymph nodes first. In non-Hodgkin lymphoma, the spread of cancer is less predictable. In 1666, an Italian doctor named Marcello Malpighi was the first to describe a disease that sounds like what we now call lymphoma. But it was a British physician, Thomas Hodgkin, whose name became associated with these blood cancers. In 1832, Hodgkin reported treating a series of patients who had died of a mysterious condition that caused their lymph nodes to become enlarged. That disease became known as Hodgkin lymphoma. Doctors eventually realized that there were cancers similar to Hodgkin lymphoma that affected other types of lymphocytes and behaved differently. These cancers became known as non-Hodgkin lymphomas. There are 4 major subtypes of Hodgkin lymphoma and more than 60 subtypes of non-Hodgkin lymphoma. Each subtype is unique and requires its own treatment plan. Non-Hodgkin lymphoma is much more common than Hodgkin lymphoma. In fact, there will be nearly 10 times more cases of non-Hodgkin lymphoma diagnosed in the United States this year. These 2 types of blood cancer tend to affect different age groups. Hodgkin lymphoma primarily occurs in people under 40. Younger people can develop non-Hodgkin lymphoma, but more than half of cases occur in people over 65. Both forms of lymphoma are more common in men than in women. Your risk for certain types of lymphoma is also higher if you have been infected with the Epstein-Barr virus. Lymphoma seems to run in families, so your risk is increased if a close blood relative had this cancer. The same is true if your immune system has been taken by another disease, or you take medications that lower your immunity. In early stages, Hodgkin lymphoma and non-Hodgkin lymphoma may not cause symptoms. However, patients may develop swollen lymph nodes in the neck, underarm, or groin. Other symptoms include fever and night sweats. Some people with lymphoma lose weight without trying. They may report feeling itchy, especially after bathing or consuming alcohol. Or they may simply feel tired and lack energy. The treatment a doctor recommends for lymphoma will depend on which form and subtype you have, whether the cancer has spread, your age, and other factors. Treatment options for people with lymphoma include chemotherapy and radiation. Patients with lymphoma that's hard to treat or that may be candidates for a stem cell transplant, in which healthy blood-forming cells are infused into the body. However, there are new treatment options available for patients with lymphoma. One is called immunotherapy, which makes the body's natural defense system stronger and better able to shrink tumors. Another new option for lymphoma is a group of drugs known as targeted therapies. These medicines take aim at specific gene mutations or proteins that cause cancer cells to grow and spread. Targeted therapy and immunotherapy have improved the treatment of lymphoma and the lives of patients. However, there's another option for many people with lymphoma. Enrolling in a clinical trial can give you access to new therapies months and even years before they're available to other patients. These advanced treatments can be life-changing, and some may even offer a cure. There are currently over 1,700 clinical trials of lymphoma treatments underway or getting started around the world. Give yourself the gift of hope by learning about all of your lymphoma treatment options.
We are back. Thank you, everyone. We have some questions. I think we're well over time, but we'll just answer one or two of the questions. The rest of them will be posted on our site later today or tomorrow. So one of the questions that I would like to ask here from one of our viewers is, my initial treatment plan was 3 years of Bruxens, and I may be saying that wrong, and Revlimid. I have finished that plan, and now I'm not taking anything. Should I be taking Revlimid until the MCL returns? I have read conflicting reports, and my doctor says to continue Revlimid.
Excellent question. So that is a treatment. One of the ones that I was talking about, that is the combination, that medication that starts with an R there, Rioxin, is actually rituximab, right? And Revlimid is lenalidomide, right? So that we call that regimen R squared. Okay, it's quite active in patients with newly diagnosed mantle cell lymphoma. And usually, like our viewer, our patient is asking, it's usually for 3 years. Okay, it's like usually the combination is for 3 years. Okay, and I'm glad that she did really well. And there's a follow up already to, I believe, more than 8 years on that clinical trial. Actually, in the center that I work at, Moffitt Cancer Center, they participated on the clinical trial. It was based on Cornell, but there are some centers, and one of them was Moffitt. And there is still some, patients that are still nowadays ongoing in complete remission, doing really well with no problems. However, I do agree that we should not go beyond the original data, that is a total of 36 months and total of 3 years. So I agree with that. And it's good to take a rest, right? And being at rest from treatments, right? And that's why we usually recommend this, even without this type of treatment, like we talked about, for 3 years. But yeah, no, I agree that we should rest a little bit, all right? And that's good for several things. Not only to decrease the side effects of the medications, all right? And give a rest also to those mantle cell lymphoma cells that right now are sleeping, nowhere to be found, thank God, right? But if we keep on pushing and pushing and pushing, sometimes, and this is theoretical and has been demonstrated in some what we call preclinical in the lab, right? Sometimes just pushing and pushing and pushing, may create more sort of like defense mechanisms of the cells to become resistant, right? So there's a lot of good things of why to give those sort of like therapies that are limited, right, in a way. And that's a very good treatment. I'm very glad that the patient is doing well, but I would agree that it's okay to stop right now based on the clinical trial and on the data that we have. Right.
Great, great. And we'll do one more question. This one is from Massive Bio. It's from Beth. It says, do you match from studies that are paying for recruitment, or do you match with other research studies also? So Massive Bio works with a few sponsors or pharmaceutical companies to assist them in enrolling patients in their clinical trials. But what I love about Massive Bio and why I am so passionate about it, in addition to clinical trials, is we help every cancer patient that comes to us. We don't get paid for a lot of, what we do, and we're okay with that. We help any patient regardless of, whether we are working with a sponsor for that cancer type. So if there is a sponsor out there that we're working with for lung cancer, for example, if you're a lung cancer patient, we'll help you regardless of, if you qualify for that sponsor's trial or not. If we're not working with a lung cancer sponsor, we'll help you. You never have to pay us. We never charge a fee to anyone. So in answer to your question, do we match studies for patients, that we are not working with a research sponsor? We absolutely do, and we never charge a fee to anyone. So I'm happy about that, and it warms my heart that we continue to do that. So
Excellent. Very
yeah.
good.
All right. So Dr. Sandoval, thank you so much for your time. I appreciate it. So informative. I know, patients are happy to hear what you have to say. We thank you for everything you do for patients and their caregivers. We'll let everybody go now. Any questions that are posted that we didn't get to, we will respond to and share after.
Absolutely.
And for anyone interested in reaching out to Massive Bio, you can contact us, on our website, massivebio.com. You can contact us on Facebook, and also by email to support@massivebio.com. So thank you, and everybody have a great evening.
Thank you very much. You have a great evening. Thank you.
Thank you.